Welcome to my channel Pediatrics and Life Tips. In this video, I will talk about pediatric obstructive sleep apnea. I will start with two cases. Case number 1 is this boy in the picture presented with a history of marked snoring every night. He also has shortness of breath on exertion and excessive daytime sleepiness. He has been diagnosed with Prader-Willi syndrome. Now look at both these pictures and answer the questions. Question number 1 is, what investigation is performed in the second picture? What does the result show? And what other investigations would you request in this patient? Now the answer. The test shown in the picture is overnight pulse oximetry. It shows episodes of severe oxygen desaturation during rapid eye movement sleep with a corresponding rise in the heart rate. Answer 2 is the diagnosis is obstructive sleep apnea. And the other investigation which should be done in this patient are ECG to look for the right ventricular hypertrophy and echocardiogram to exclude right heart failure. Case number 2. You are seeing a 7-year-old boy for the first time. His mother complained that he always seemed sleepy during the day and that he has started complaining of headaches. His school teacher has also sent a note that he has difficulty in staying awake in the class. The boy also wakes up the whole house with his loud snoring at night. MCQ for this question is, which of the following is most appropriate next step in evaluating and managing this condition? A. Refer to otolaryngologist for tonsillectomy and adenoidectomy. B. Arrange for continuous positive airway pressure at home. C. Try steroids to decrease tonsillar and adenoid hypertrophy. D. Arrange for home oxygen therapy for use at night. And E. Arrange for polysomnography. Now the correct answer is E, that is arrange for polysomnography, which is the overnight sleep study. Now a nasopharyngeal airway, the use of nasal continuous positive airway pressure, tonsillectomy and adenoidectomy, they are all effective treatment for obstructive sleep apnea. But in this case, as the child is having loud snoring, the diagnosis of obstructive sleep apnea should first be made by this polysomnography to exclude other causes of snoring. Now I will discuss in detail obstructive sleep apnea in children. I will give 3 important definitions. Now first is the sleep disordered breathing. It encompasses a broad spectrum of respiratory disorders that occur in or are exacerbated by sleep. It includes primary snoring, upper airway resistance syndrome, apnea of prematurity, central apnea, and obstructive sleep apnea. Now, obstructive sleep apnea is defined as a respiratory disorder that is characterized by repeated episodes of prolonged upper airway obstruction during sleep, despite continued or increased respiratory effort, resulting in complete or partial cessation of airflow at the nose or mouth, as well as in disturbed sleep. Primary snoring is defined as snoring without associated ventilatory abnormalities on overnight polysomnography or respiratory-related arousal and is a manifestation of the vibration of oropharyngeal soft tissue walls when an individual attempts to breathe against increased upper airway resistance during sleep. Now I will discuss the etiology or risk factor for the obstructive sleep apnea. First is the anatomic factors which can lead to narrowed upper airway. These include seasonal or perennial rhinitis, adenotonsillar hypertrophy, macroglossia, cleft palate repair, pharyngeal reactive edema due to gastroesophageal reflux disease, obesity especially in the case of Prader-Willi syndrome, micrognathia, retrognathia, mid-face hypoplasia as in Down syndrome, mandibular hypoplasia as in Perry-Robin syndrome, or achondroplasia. Second important factor is the increased upper airway collapsibility due to reduced tone, and these may be present in hypotonic cerebral palsy, muscular dystrophies, and hypothyroidism. Third important risk factor for obstructive sleep apnea is reduced central ventilatory drive, which may be present in the case of Arnold-Chiari malformation, meningomyelocele, and rapid onset obesity, hypothalamic dysfunction, hypoventilation, and autonomic dysregulation syndrome. Now, the prevalence of pediatric obstructive sleep apnea as defined by the parents' reported symptom is 4 to 11%, while as documented by overnight sleep study is only 1 to 4%. And the peak age is 2 to 8 years, and it is more common in boys. It is common in all ethnic population, however African Americans and Asian children are more effective. There is also a history of prematurity, and family history of obstructive sleep apnea is usually positive in these children. Now I will discuss the clinical features. First, the sleep-related signs and symptoms. These include loud, frequent, disruptive snoring, breathing pauses, choking, gasping, arousal, restless sleep, nocturnal awaking, abnormal sleeping position with hyperextended neck, nocturnal diaphoresis, sleepwalking or sleep terror, secondary enuresis, and difficulty in morning waking. Daytime symptoms include early morning headache, daytime sleepiness, drowsiness, mouth breathing, dry mouth and difficulty in swallowing, poor appetite, chronic nasal congestion or rhinorrhea, hyponasal speech, and poor appetite. Now, in these children, obstructive sleep apnea related morbidities and complications are common, and these include mood instability and irritability, depression and anxiety, hyperactivity in attention or aggression, academic difficulties, pulmonary hypertension, right heart failure or cor pulmonale, systemic hypertension, insulin resistance or diabetes mellitus, dyslipidemia, and poor somatic growth. Now the diagnosis. The gold standard test for diagnosing obstructive sleep apnea in children is the in-lab overnight polysomnography, that is the sleep study. It includes measurements of oxygen saturation, cardiovascular and breathing parameters, chin and limb movement, eye muscle movement, and brain electrical activity recording. Second important test is the overnight pulse oximetry with video monitoring if polysomnography is not available. In overnight sleep study or pulse oximetry, measure apnea-hypopnea index. This is the number of apneas and hypopneic events per hour of sleep. Now, in a normal child, this index is less than 1.5, and in normal adolescent, it is less than 5. Obstructive sleep apnea is diagnosed if this apnea-hypopnea index is more than 5, or it is 1 to 5 plus obstructive sleep apnea related morbidity or risk factor. It can also be diagnosed if there are 3 or more oxygen saturation drop less than 90% and 3 or more clusters of desaturation events, or desaturation index is 3.5 episode or more per hour. Now, if overnight sleep study and pulse oximetry is not possible, then still we can diagnose obstructive sleep apnea in a child on the basis of 3 criteria. The first is frequently or almost always loud snoring plus male gender. Second is frequently or almost always loud snoring plus sleepiness. And the third is frequently or almost always loud snoring plus learning problems. Now, the treatment of obstructive sleep apnea consists of a stepwise approach. First is the weight control for obesity. Then positional therapy, that is attaching a firm object such as tennis ball to the back of sleep garments to prevent child from sleeping supine. Then trial of nasal corticosteroids or leukotriene inhibitors to decrease inflammation of the adenoid or tonsils. Then adenotonsillectomy, and treat seasonal allergy, gastroesophageal reflux disease, or asthma if present. Now, the orthodontic devices can be used for mandibular malpositioning or narrow maxilla. Myofunctional therapy is the exercise to address abnormal tongue position and low upper airway tone. Nocturnal continuous positive airway pressure is used for residual obstructive sleep apnea after adenotonsillectomy, and also for obstructive sleep apnea which is related to obesity, neuromuscular disorders, or craniofacial abnormalities. Now, if all other measures fail, then craniofacial surgery or tracheostomy can be used. Thanks for watching this video. Please like, share, comment, and subscribe to my channel.